All right, well, welcome everybody to our Cancer Prevention and Control Program, Scholars Program webinar. Let me say that again because there's so many acronyms. Whoa, let's restart the recording again. Welcome to our Cancer Prevention and Control Research Network Scholars Program webinar. That is a mouthful, but we are excited that you're all able to attend. Our webinar today has an exciting title, Implementation in Action, CPCRN Investigators' Experiences. My name is Daniela Friedman. I co-lead our CPCRN Scholars Work Group with Dr. Escoffery, who is one of our presenters today. I am so pleased to welcome our esteemed panelists. So we have Dr. Alison Brenner, who is Assistant Professor in the Division of General Medicine and Clinical Epidemiology. She is with the Lineberger Comprehensive Cancer Center at University of North Carolina in Chapel Hill. And we have Dr. Escoffery, who is Professor in the Department of Behavioral, Social, and Health Education Sciences in the Rollins School of Public Health at Emory University. So we are very excited to have Dr. Brenner and Dr. Escoffery with us today. Our panelists are going to describe implementation initiatives that they have been involved with, which is going to be really beneficial and helpful for all of us. I'm really excited to hear about the work that they've been doing. They'll each present for about 15 minutes, and then we're going to have a moderated discussion. And of course, after that, we want to open it up for a Q&A with all of you. So while our presenters are discussing their projects, you're welcome to include questions in the chat box, and we will get to those. And you're also welcome to wait until the end and ask questions then as well. So without further ado, I am going to pass it off to Dr. Brenner first, and you have access to share slides.
Okay.
Because we are very high tech as part of our work group. And we look forward to hearing about your implementation science work.
Okay, so, screen failing. Okay, so you guys, I went ahead one already. You guys are seeing my slides, not my presenter view, correct?
We are seeing your presenter view. We can see your notes, so I think we just have to hide that, and you will be set.
There we go. Now we should be seeing the correct thing.
Excellent, wonderful.
All right. So thanks everyone. I'm Alison Brenner. I'll skip my inbuilt introduction because you did a great job, Daniela. I'm going to discuss a program today to address implementing colorectal cancer screening in underserved populations. I'm going to go back to some of the work that has led us to the idea that we eventually got funded and we're now implementing. We've done a ton of work over the years that led us to a good fundable idea, and now we're doing it. So come on. Need to be able to advance my slides. All right, there we go. I first wanted to do a really brief overview of colorectal cancer screening just to get us all on the same page, because I'm going to use some acronyms. It's a cancer that starts as small growths in the colon or the rectum. It can be screened for using kind of two different types of tests. One is a structural visualization test group. The most common is colonoscopy. The other are stool-based tests where a kit is sent home where a patient can take a sample of their stool and it's sent to a community laboratory to look for hidden blood. The one that I'm going to be talking about quite a bit is the fecal immunochemical test, or FIT kit, is what we've used. All right, so that very brief overview let's go back in time. I've worked in CRC screening implementation throughout my career. In these kind of 15 to 20 years in the field, national screening rates have increased dramatically. About 15 years ago, rates were probably in the upper 40s nationally, and pre-COVID, average rates around the nation were probably in the low 60s, 62, 65, somewhere in there. But in underserved populations, particularly those primarily served by safety net health clinics, both community health centers and federally qualified health centers, they tend to have substantially lower rates. So this slide shows in orange the FQHC population and in blue the general population over several years. And you can see that in 2018, the FQHC population hadn't even gotten to the 2012 numbers of the general population. So area ripe for intervention. In 2015, an article came out showing that there were 3 distinct areas of the US that showed higher than expected mortality rates from CRC. One of those areas is in northeastern North Carolina. We performed some confirmatory analyses using more recent data, and we're able to see the same trends in these kind of northeastern 11 or 12 counties. So we thought focusing our intervention there was probably a good idea. Simultaneously, our group is also working on some modeling to find out what intervention or interventions might be best to improve CRC screening in North Carolina. This is some of Stephanie Wheeler's work from several years back. Many of you know her quite well. The upper map shows the number of endoscopy facilities per county. Those are those little tiny numbers in the counties. What was interesting is that and the colors refer to the rate of colorectal cancer screening at the time she did the analysis at the county level. So what was interesting about this analysis is that the number of endoscopy centers was not necessarily predictive of the rates of CRC screening in the county. So a couple of places to kind of key into. So right here in this kind of the mid orange is Orange County, where Chapel Hill is. See, there's one endoscopy facility, that's UNC. It was kind of in the mid or higher range of CRC screening. But down here, this big county right here is Mecklenburg County, that's Charlotte. There are 17 endoscopy facilities, and they are in the lowest rate of CRC screening in the rate bucket in the state. So that was interesting. She also modeled some cost effectiveness of an impact on this cost effectiveness frontier of a variety of types of interventions using her big simulated population models, which some of you in this group know a lot more about than I do. And what we saw was this little red block right here, the mailed reminder, was really kind of the best bang for the buck. You can get a lot of people access to screening for not a lot of money. So we wanted to, it appeared that that was kind of the best deal. So following that analysis, we decided to focus on Mecklenburg County, where they have 17 endoscopy facilities, and specifically Medicaid beneficiaries. Her whole analysis had been in a simulated Medicaid population. So using claims data, we identified beneficiaries due for screening, and health departments randomized them to receive either a mailed reminder for CRC screening saying that they were due, or a mailed reminder with an included fit kit that they could do at home and send back to the health department for processing. And we were able to see that, so 21% in that fit plus reminder group versus 12% in the reminder only group got screened. And it turned out that it was also cost effective. Again, there are a few of you in this group that know a lot more about that. And from some perspectives, actually, including a fit kit in that mailer was dominant. So we were pretty keyed into the idea that mailed fit was a good response. We also, and this is all leading up to our implementation project that I'm going to tell you about, we also did a systematic review to see what else was out there, to see if this was holding up across the literature. We ended up reviewing 73 studies, 78 papers. It was a big review. And what we found there was that stool test outreach, so these mailed fits, was the kind of the best in terms of efficacy in a clinical population. Patient navigation wasn't too far behind it. So this is helping people on a one-on-one basis to get to screening completion in some way. And a few others were impactful in getting people screened. We particularly saw that multi-component interventions were better than any single intervention on its own. So we had that out there. We also then had a really cool opportunity to participate in the CDC sponsored summit on how to do mailed fit. So we got together all the people in the country that are kind of working on this at the high level. And we sat down and went through every single step of how you do this. And we came to a consensus on the different steps and produced this kind of roadmap paper on how to do it in clinical settings. It was a lot of fun, and definitely the most specific conference I've ever been to. So then kind of the perfect funding opportunity rolled around. This was great. The Cancer Moonshot Blue Ribbon Panel recommended colorectal cancer as one of their priority research areas. And they produced this RFA called AXIS. AXIS stands for, it's a mouthful, Accelerating Colorectal Cancer Screening and Follow-Up Through Implementation Science. So perfect. It supports research to build the evidence base on multi-level interventions to increase the rates of colorectal cancer screening, follow-up, and referral to care, focusing on underserved populations with lower than average CRC screening rates. So it's really looking at these vulnerable populations that need implementation. I'm sorry, need intervention, not implementation. They also need implementation. This is a spoiler, we did end up getting funded on the first round. They eventually funded 5 research programs. These are they, including ours, and 1 coordinating center at RTI International. So what did we propose? Well, we started by considering our target audience, the underserved populations with low screening rates in federally qualified health centers. Remembering back to that graph that I showed you earlier on with the FQHCs having much lower rates than the national average. So the first question that we asked ourselves is why are those rates so much lower? It's multifaceted, of course, but it's not because the doctors don't know that they're supposed to be doing this, and it's not because the patients don't know that they're supposed to be doing this. It's often a problem of opportunity. So it's either patients who are coming in or have chronic conditions, they have other things going on that something like a preventive service like colorectal cancer never rises to the top of the agenda. There are also the patients that aren't coming in, so there's no opportunity to talk to them in that sense. So we thought this was kind of a perfect spot to do mailed fit outreach. It will reach patients that aren't coming in. It'll reach patients for whom it doesn't rise to the surface on the agenda. So we kind of use this a combination of this capability, opportunity, motivation for behavior change and the behavior change wheel, which are highly related, and use that to build our proposal around. So we proposed an intervention called SCORE. It's again a mouthful, which is why we call it SCORE. It's Scaling Colorectal Cancer Screening Through Outreach, Referral, and Engagement. The aim of this project is to build and test a centralized mailed fit outreach intervention to improve CRC screening and follow-up in community health center populations. So our intervention was mailed fit that, given you kind of the background on, and our implementation strategy was really the centralization. We really wanted to take this away from the clinics and do something for them. So we have brought the mailed fit effort. We call it our central mailing center, but it's really our office in Carborough, where we package up all these fit kits and send them out to their patients. There are a lot of stakeholders involved in this process. The FQHCs in the hospitals, of course, the endoscopy providers, charity care programs, our advocacy groups, the community labs, the academic centers, including our own. I think we gathered for this proposal about 20 letters of support, maybe more. When I've looked at that list, it's made me exhausted and thinking about how long it took to engage with these groups to get those letters. We've really had a tremendous relationship with a lot of these folks, but it's definitely taken time. So our goal was to get more people screened for, here, I'll go through the fancy animation, was to get more people screened and reduce the burden of CRC among underserved North Carolinians. This is a huge problem with lots of different facets. We had to break it down into some chunks in order to approach it. But one thing that was very cool about this funding opportunity is that it was very specifically broken down into a planning and exploratory phase and then an implementation phase. We're now in the implementation phase, but we had some time to really step back and figure out how we were going to approach this. So we went into the proposal with this pretty complex randomized control design as to what we would do in our implementation phase. But in the whole goal of this early phase was to say, is this what we want to do? So we tested out a lot of these things. We quickly nixed out this arm 4, the mailed reminder plus fit plus inReach. So this inReach part was somebody actually at the clinic to chase somebody down who hadn't done their fit. And what we realized was that really didn't fit with the whole centralization and pulling things out of the clinic model. It was also very resource intensive. We've done this in smaller studies and it just takes a lot of work. So we wanted to see what we could do without having anybody in the clinic actually doing active work on this. So I'll go through a little bit of our planning and exploratory year. These are our 4 working groups, and we did a lot of stuff over the course of the year to get ready for the implementation phase. So there was the screening, registry, and data work group. I led this work group, and we used this body to standardize patient identification protocols. So we're doing this in as automated a way as possible. So we're querying the EHRs to find people who are due for CRC screening and also eligible for FIT. We developed a screening registry of the patients that we could use to track the patients in real time and navigate them through the screening process. So have we sent them a FIT kit? Have they responded? Do they need a replacement one? What is the outcome of their FIT results, et cetera? So the next work group was used to develop and pilot test our mailed fit outreach materials protocols and to figure out how to get the test results back into the clinical EHR. So this is a huge data problem. So we ended up creating our own account with the community lab, but we had to get it linked with the clinical EHR so that the physicians would know that their patients had done a FIT and what the results were. We also had to address the whole issue of if you have an abnormal FIT results, you have to get a colonoscopy, and there needs to be, this is a big problem with FIT programs. It's hard to get in for colonoscopy. So we had a whole group of people dedicated to this problem to develop these protocols and to test referral and navigation processes. So we have a dedicated patient navigator to help our abnormal FIT patients get to follow-up colonoscopy. And we've developed transportation programs and financial support programs so that we can help them get to the colonoscopy and pay for the colonoscopy. And finally, we wanted to do this with sustainability in mind, so that, when our research dollars are gone, we're not going to just walk away and say, you're on your own now. We're doing our best to see if we can figure out a new home for this once our study period is done. So we've used system science methods to refine and assess implementation processes with sustainment as a priority. We've developed implementation outcomes measures, including cost and cost effectiveness, so we can see, okay, who do we need to talk to get the money to keep this going? And we've identified and described local innovations. And this kind of has dual purposes. One is, is there stuff out there that we haven't thought of that people are already doing that we can incorporate into our protocols? And 2, are there some spots out there that are potential new homes for this once the research dollars are gone? So we did many PDSAs, each time learning something new. I'll go through this super fast. We iteratively revised our patient identification query using a combination of automated query and chart review for validation. This describes the process at one of our community health center sites where we got down to a pretty good rate of accuracy that we felt good about. But in the end, we actually ended up for each set of fit kits that we send out, we do actually review each patient chart to make sure that they're eligible for fit. We revised our patient-facing materials. So one of the big things that I wanted to highlight here is, so when you're sending a test kit home and it goes directly to a clinical lab, it needs to have a test requisition form. So this tells the lab what to do with it. These were never meant to be patient-facing materials. They're for clinical staff to fill out. They're way too complicated. The first set of things that we sent out had a bunch of, crossed out sections. You don't need to worry about this. We got permission from the community lab to, it's still not pretty, but to at least pare it down to the absolutely essential information that's needed. The outreach letters, we made them more concise. We made them a little more visually appealing. And with each iteration, so we mailed out a bunch of these fit kits. My floating meeting, 587 fits. I think there might have even been a few more after this slide was created. In many different waves, each wave differed just slightly, and we learned something from each wave. We eventually got to about a 24% response rate, which is, if you happen to take in and look really quickly back in that systematic review slide, that's about as good as anyone's getting with mailed fit outreach. So we felt pretty good about that. Let's see. And now I am not advancing. There we go. So at the end of our pilot year, we ended up with a much simpler study design with 2 arms. We just, through the course of the many pilots, we found that the additional intervention, the additional reminders that we were testing out just weren't getting us much, and it was a lot of work. So there's usual care, and then there's a mailed reminder plus a fit kit. When we watch for the fits to come back, if they're abnormal tests, we provide them navigation to diagnostic colonoscopy, and then we will assess CRC screening completion via the EHR at 6 months. So implementation happens in the real world. I think that's the most important thing that I can pass on today. You'll always experience roadblocks that you were not expecting. So here we are at our trial kickoff launch, big meeting that we brought all of our community partners in, and note the date, March 10th, 2020. And we all know what happened right after that. It was 3 days later, we all got sent to work from home. Primary care visits basically stopped for this kind of thing. And here we are more than a year later, still on Zoom. I mean, I guess we'd be doing this on Zoom anyway, because we're all over the country, but still on Zoom, still doing things with masks on. We eventually have been able to launch. We had intended to launch in March. We ended up launching in one site in July, and the other site we launched a little later, a little into the fall. But it's been much more challenging than perhaps it would have been if we weren't in a pandemic year. One of our sites also happened to change EHR softwares in the middle of the year, and they're still struggling with that. We have not relaunched after the holidays there. And at this point, they are handling, it seems like, the COVID vaccination efforts for a lot of their area, even though they're a federally qualified health center and trying to do lots of other things. So that one's been a challenge. We also ended up having, this is not necessarily COVID related, but could have been related a little bit, some mail delays that resulted in some samples that were unable to be processed. So fits are viable for about 2 weeks. And if they come to the community lab after those 14 or 15 days, then the lab will not process them because the sample is no longer viable. Could be that LabCorp has also been the primary lab for processing the COVID PCR tests. It may be unrelated. It's hard. It could have been election-based mail delays, which is also related to COVID. So all sorts of interesting things. But we will eventually mail out about 1,000 fit kits per site. We are set about 70% on our way to that goal at one of the sites, and about 60% at the site that changed GHRs, and we had to slow down for a while. So this is another heat map that shows where we are with fit mailings and response now in the trial. We've mailed out 1,267 fits across the 2 sites, and 271 fits completed. So we're staying right around the low 20s in terms of response rate, which is great. The darker blue shows these are the 2 counties where we've mailed the most fit kits. Excuse me, and those are also, unsurprisingly, exactly where the primary site for the FQHCs that we're working with are located. We have had a fair number of fit positives. We've had a 68% rate of completion of follow-up colonoscopy, which is surprisingly very, very good, according to the literature. Can vary between 30 and 50% with no intervention. We have some others in progress, so we might even get up into the 75 or 80% range. Let's see. So our evaluation plan, we are collecting these measures continuously. We are evaluating at multiple levels. The patients, we're looking at screening uptake, the providers, in the clinics, we're looking at acceptability of this intervention. At the clinic level and at the centralized mailing center level, which is us, we're looking at cost. We'll collect some community census characteristics to kind of contextualize the information. And let's see. Oh, and that is the end. I'm trying to stay within my 15 minutes. In case of Zoom failures, I was put my little picture, but here's all of my contact information if anybody has questions afterwards.
Wonderful. Thank you so much, Dr. Brenner. I love the note that you had on one of your slides that said, "Good enough, let's go for it!" Exclamation point. But that was a big jump. So that was wonderful to see that data. So thank you very, very much for your presentation.
I've got a glimpse of my adorable little daughter on my desktop.
Well, we need to see her too. We're going to save questions about Dr. Brenner's implementation work. Dr. Escoffery is going to present next, and then we will have our discussion and some time for questions. So thank you so much. And Dr. Escoffery, you should be able to share your screen if you'd like to.
Thank you very much, Alison. It's always nice to hear other people's projects and your progress. Hopefully you could see my full screen now. Thank you, Daniela, for the thumbs up. My name is Escoffery. It's a pleasure to not only be one of the co-leads of this program, but to share some of our work at the Emory Prevention Research Center and our Emory CPCRN. So this is all about our core project at Rollins, which focuses on HPV vaccination promotion in rural Georgia. So wanted to kind of highlight some of our work is really grounded in our work with our Community Advisory Board. And many of you know that Atlanta, where Emory sits, is in Irvin, Georgia, and we actually work with a community 3 hours away, and we are able to kind of see them throughout the year, although not in the pandemic year, in terms of updating them on our progress and also generating ideas. And so here you see Christine and myself at one of our last meetings. Whoops, sorry. And then on the right side is some of our Prevention Research Center members. Just wanted to kind of give some faces to our work. So just as I said, Emory is here in kind of the northeastern part of Georgia and our catchment area. We wanted to focus on cancer and health disparities with our Prevention Research Center, which I'm the associate director of. So we have a really close connection between our PRC and our Cancer Prevention and Control Research Center. We work with about 30 to 33 counties that I highlighted in the green in the south west corner of Georgia. Albany, Georgia is the county seat, and it actually made national headlines in not only in Georgia, but nationally for African Americans having some of the highest early COVID kind of super spreader events. There were funerals that were happening down there in actually February and early March that became super spreader events. So those are the communities that we work with. You could see that we focus on partnerships there with our community advisory board members and also with clinics in the area around some of our topics. And our main PRC topic is focusing on obesity or weight gain prevention. And they're working with a 211, which is a call center in a couple of these areas to recruit patients to work on healthy eating. So our project is focused on HPV vaccination. So I'll just kind of give you some highlights. HPV, if you don't know, is one of the most common STIs. A lot of people think HIV and things like that, but it's actually HPV. Nearly 80 million people are currently infected, and how we help with HPV is vaccination. Vaccination actually helps with protecting most people of preventing it, and it covers and presents about 90% of HPV related cancer. On the right, you can see some of those HPV related cancers, the most common in women being, of course, cervical, but for men, you also have anal and oral phalangeal, which are mouth and throat cancers as well. And actually those cases are really going up. It's recommended that the vaccination be given at ages 10 to 12. And then because the vaccine is newer, I would say, since 2006, there's a lot of catch-up population with young adults also needing to get the vaccine to protect themselves. The reason we're focusing on rural Georgia is, of course, in rural Georgia, it does have not only for cervical cancer, but a lot of cancers, higher rates in our urban Georgia counties. And we found that there is like a 9% difference in terms of vaccine uptake, at least for the first dose in residents of adolescent ages. And so it's like 90% lower among those who are in rural than in urban settings. And that's trends is also national. Just to hit some highlights of where we need to go, you can see in the blue box that really we're only around 50% of adolescents getting their vaccines completed. And then the last two bullets are young adults. And really what I call the catch-up population is that rate is actually much lower. You can see it's only 40% in 2018 of the young adults receiving their complete series. So we have work to do. So the Emory Cancer Prevention Control Research Center, we have a couple of different aims. And I'm going to cover the last three aims, which is really our research aim. We do a lot of work in concert with the other centers for our aim 2 and 3, which are kind of national in scope. So into our first aim, we are doing a qualitative study that will tell us a little bit more about HPV vaccination in rural Georgia. We're doing interviews with different population groups, and you can see them in the table here: parents with vaccinated and non-vaccinated kids, adolescents who have been vaccinated, young adults, and then we have two different provider groups. We are in the midst of these, and as Alison said, COVID happened. We got our IRB recruitment, and we started having some early interviews, and then we had to stop, and we have ramped up again and are conducting these actual interviews. The framework, I always think you might want to understand what we're using to describe our work, and so we're using a theory for deductive coding, and the theory is by one of our Emory co-investigators, Bob Monarzik, and if you're interested in it, it's linked down below. But the graphic here really just shows you what this is about, and I'll share the the slides with you later if you want to look at it more closely. I just thought we would share that it focuses on the practice level. So what is it about the healthcare system? Do they have materials in different languages? Do they actually have materials? What do the providers do in terms of recommendations and communications? How strong are their education points? And then what do the patients know? And so I gave you some examples here of questions that we're asking in each of these areas to understand the different levels and how that might affect vaccination. The other formative work we're doing that is almost complete in terms of at least data abstraction is we're doing a systematic review. We're updating one of interventions that were done up to 2016 and looking at what interventions have been published in the literature. Some of the research questions are highlighted in the second bullet. Who are their audiences? What intervention strategies are they applying? And what levels of social ecologies are at these different types of intervention? Are they single level? Are they multi-level? I know actually in the US, we probably have more lower levels. In other countries, they actually have like school mandates for vaccination and things like that. So that's what we're curious about is how do some of these differ? We're using, of course, the PRISMA guideline. If you want to do systematic review, you have to follow those guidelines. So I have that link below. And this is a nice cross-center. When we come to Q&A, I always value my cross-center collaboration. So we did invite researchers from other centers to kind of work with us in doing the data abstraction. And this is a way, again, like you could get involved in CPCRN in a way to do that. Our big phase 2 project is evaluation of multi-level interventions for HPV vaccination uptake. This will happen actually towards the end of this year, we'll start this. And the way we're doing the evaluation is we're applying basically a capacity building model that will be mini grants and providing technical assistance to community partners. And most of them probably will be clinical partners. And so we're funding these mini grants in 2 cohorts. They'll receive some funds and they have to be health departments, health systems. They could also be school or community-based organizations that offer the vaccines. So those are going to be our delivery system partners. And some of them we've already had some contact with in terms of the interviews. Our methods is to get them to understand multi-level interventions. And you will see here on the right, these are some examples of what they could choose. And we're asking them to at least work with 2 levels. So those of you who are interested in multi-level interventions, this is the way we design it. So they could choose things at the individual level, which might be print materials or sending letters or emails to parents to remind their adolescents or young adults. They could choose a provider level, which might be training their provider or having their providers make stronger recommendations and practicing that. And they could also choose practice level. These are all based on evidence-based strategies. If you're interested in our use of mini grants, I put 2 articles. One of them is actually use of mini grants to disseminate evidence-based interventions. Is 2 cycles ago in CPCRN, a lot of our different sites were employing mini grants. So this kind of gives you an overview of that strategy. And then the one by Kimberly Jacob Areola is one of our investigators, and I'm on this, is how we use mini grants with faith-based organizations to implement evidence-based strategies. Our primary outcome once we have their training and helping them get started with their multi-level intervention is to look at changes in rates of both initiation and completion of the HPV vaccine series. And completion will depend on, again, the doses schedule. If they're over 16, they have to do or take 3 doses versus the 2 doses. We did map the evidence-based interventions into evidence-based recommended strategies, and the places that we found them. So those of you who are interested in evidence-based public health, we use community guide strategies. I have the link for that below. But they could also use package programs at any one of these levels. And those package programs are located at that evidence-based cancer control programs, which is the new RTIPS, research tested intervention program. So you can, those are repository for evidence-based strategies, and we base a lot of our interventions on that. So again, these are just mapping them onto what the implementation science world knows as implementation strategies, which are just actions to enhance the adoption and implementation and sustainment of evidence-based interventions. So we have some at the individual provider and practice level. And if you're interested in using intervention strategies, I really like this article from Enola Proctor, who helped us coin and group the different types of intervention strategies with Byron Powell. And this one, this article gives you a really nice step-by-step guide of how to use intervention strategies, but also how to report it in your publications. So what are we doing in terms of implementation research? I'll cover this pretty quickly, but we're really looking at how the different health systems are implementing the program, and our theoretical framework is the Consolidated Framework for Implementation Research. I have some of the questions that we're interested in here. So we're looking at intervention outcomes like appropriateness, acceptability, and feasibility. We're looking at if the interventions were delivered with fidelity to the intervention at different levels. Some of that is easier than others. We're looking at barriers and facilitators, and penetration, which is a subset of reach, is like how many adolescents or young adults are in their patient population in the last year or two, and then how many of those did they reach with actual vaccination. Our data collection for this part of the intervention will be sequential mixed methods, meaning we'll do surveys of implementation with interviews, so quantitative and qualitative. Our data points are getting some baseline information about vaccine rates and what they currently do. And then of course we have the implementation of the interventions, and then we're asking implementers and providers at 6 and 12 months about implementation. We're also collecting data from parents about what they see or their thoughts about these interventions. And then to complement the qualitative, I always feel like for delivery and understanding of delivery in different settings that you need to get their voices. So we're actually conducting interviews with 3 staff from each site at a minimum, and asking about some of the same questions to get some of that more in detail. What do they think about the intervention strategies, the training and TA, and aspects of implementation that they want to share? Our analysis for both phases will be qualitative and quantitative, and we kind of use a pretty similar qualitative approach to data analysis with code with development. Most of our coding will be deductive because we have theoretical kind of underpinnings, the P3 model for our qualitative interviews, and CIFAR for implementation. And then we'll be developing matrix coding. And then of course, quantitatively, we'll be looking at changes in HPV vaccination rates pre and post test, and understanding delivery a little bit better. Some of the guiding principles we have in terms of some of our work is making sure we have stakeholder engagement kind of throughout the process. Our community advisory board actually helped us decide on HPV. We actually came up with a lot of different ideas and discussed it with them. And we wrote the grant towards their wanting to focus on HPV vaccination in rural Georgia. So that shows you how you can really have them invested in grant writing all the way through program implementation. They have also helped us, Christine can attest to this, with a lot of community outreach, I think for both, but in our phase 1 interviews, really passing out flyers and helping us with recruitment. I'm a big fan of applying implementation science theories and frameworks. As you could see, there are a lot of those embedded in the implementation research with our phase 2 multi-level intervention evaluation. Through the application of our research questions and our frameworks, I think we can understand the context for implementation a little bit better. With our evaluations, we're going to have different types of intervention sites. Some might be clinics, some might be FQHCs or pediatric practices. So we're going to understand that. And the other thing that I really like is to employ mixed methods to better understand implementation. So whatever you have in terms of implementation ratings on acceptability or feasibility, you all also want to complement that with understanding their delivery and getting their testimonials about their experience. So that's, in a nutshell, a couple of projects that we're undertaking that apply implementation science. And this is our bigger team, but Christine and I are the main contacts, and I'm happy to answer any questions you have. So thank you for letting me share. Back to you, Danielle.
Wonderful. Thank you so much. And you all probably noticed that both presentations mentioned systematic reviews. It is a big, I would say every project, cross-site project that we seem to do as part of our CPCRN always involves some kind of review, but they've been really helpful to guide what we do next. And so having that piece, whether it's used as a standalone project or formative work, it's been interesting to see how many initiatives have involved some kind of review paper. So that's great. And COM, as you know, our mini grants, community mini grants program that we have here in South Carolina is guided by the work that you've all done at Emory. So that's been really helpful for us. So thank you. All right, I had a couple of questions and then I want to open it up to those on the call. You both mentioned working with a number of partners. I think, Alison, you had mentioned getting 12 plus or 22 plus letters of support for your grant. You're working with multiple clinics, screening centers. COM, you showed a beautiful picture of your advisory board and partners that you're working with. Can you talk a little bit about how do partners get involved? How do you involve them? Is it, right from the start? Are they involved with how you conceptualize the project? Does it depend on who they are? Kind of how do you get them engaged? I think that would be helpful for our scholars to learn a little bit more about how to get them, how you work with partners in a little bit more depth, in 2 minutes or less, in a little bit more depth, if you could share. So COM, you're unmuted. Do you want to go first?
Sure. So I think I had the benefit of working with our Prevention Research Center Advisory Board from the very start. I actually was only a co-investigator in the early days, but they actually have been, and of course the membership changes over time. Is actually 15 years since we were first funded as a Prevention Research Center. So we basically meet with them at least 4 times a year, and sometimes we have annual retreats every couple of years to do some decision making. And if there are new grant opportunities, we bring it to them. So, when we were refunded as a Prevention Research Center, we were able to apply to the CPCRN. And so, I think the nice thing with that is we engage them in brainstorming different ideas, of course, based on our research strength. So, we can give them a lot of options that we feel like we could bring to the table, and then we have discussions with them. And then they actually helped us, we had a vote on it, and then we wrote the grant focused on HPV prevention. We give them updates on all of our projects, and some of the updates might just be, as Christine can attest, help us recruit. We're in, doing qualitative discussions with community members. So some of them actually have been our interviewees or passed out flyers because we can't quite travel there as much. And of course with COVID. And so we've been able to recruit some with their engagement. And then of course we come back and present not only the articles later on, but we actually present some of our early findings to the community advisory board members and kind of discuss some of the findings. So we engage them in a lot of different parts of the process.
That's great. And I think it's interesting for everybody to hear that even deciding upon the focus of the grant, how they're involved and voting on the topic, that's really interesting. Thank you. Alison?
Sure. Yeah, ours. So if you guys can remember back to that, one of those initial slides, the 2015 article that kind of highlighted this northeastern corner of North Carolina, and our subsequent confirmatory analysis, we were looking for a partner in that part of the state and connected with another faculty member here at UNC who had worked with that community health center in a larger intervention study, and just said the CEO is dynamite. And we went up there, he connected us to her, and she's on like every board in North Carolina. We were also had maintained some connection with the Community Health Center Association in North Carolina, which is our primary care association, RPCA here. And they kind of helped us to link out to the other site that we've used for SCORE with those connections, and the colorectal cancer roundtable at the state level that we participate in. We've met some of our GI colleagues that have helped us to develop the endoscopy networks that we have. And it's been, kind of what I guess you'd call snowball recruitment on that one, meeting people through meeting people through meeting people. But they, we went to them with the research idea. We gained their support, and we used a lot of collaborative process mapping work to develop the specifics of the intervention with the clinical staff. And we say, what do you do? How can we, where can we take over the process? Where does it need to go through you? And really got buy-in along the way for what we wanted to do. We definitely said we'd love to do a mailed fit program. Does that sound good to you? So it wasn't quite as grounded as what Dr. Escoffery was presenting, where they came up with the particular topic. But they were all bought into it, and have been consulted as far as the protocols along the way and have participated in that process.
That's great. You reminded me of an article that I just found and read earlier about innovation champions and the idea of having champions. And it sounds like that first person you mentioned who's been involved with you along the way, those are people who really advocate and can be involved in that snowball recruiting of other partners. So that's fantastic to hear.
Absolutely.
That's great. I'm going to save my second question to right at the end, because I want to see if any of our wonderful scholars and attendees and participants have any questions for our speakers. And you can go off mute, or you can type it in the chat box. And maybe that was your question. You wanted to know about partners.
That was actually my question, Daniela, but I'll go off of that a little bit. And Dr. Brenner, you talked about the sustainability piece. Can you talk about kind of how the partners may or may not fit into that sustainability piece?
Yeah, great question. The central tenet of our project has been this, not having them do the mailed fit outreach piece. So we've really been struggling with where does this live? So we don't just create this beautiful program and then put all the work back on them, because they've all been very appreciative and they've liked it. And it's they had these two sites actually had pretty good screening rates to start off with, because they're very activated. But like any other FQHC, they don't have a lot of extra time. I'm hoping that we're kind of reaching right at that point where we're making that decision and we're trying to figure out that entity. And so that one's somewhat TBD. But we're definitely working with all of our partners to figure that part out.
It's a great question. I don't know, Com, did you want to add anything about sustainability of partnerships from your end?
Yeah, I think in terms of our work with both the CPCRN and our Prevention Research Center, it's ongoing work. I won't say that it's always easy. We want to make sure we capitalize on people's experience. And typically we ask for a 2-year commitment just so that they get to know us and some of our activities. But I think maintaining interest in our work. We have taken on other COVID projects with them because they were really interested in understanding lower rates of vaccine uptake in certain population, even certain medical staff. So I think being really amenable to working on other things, although it might be adding things to your plate. So I think there's always compromises that you have to do. And then, of course, getting new people engaged. So keeping our advisory board members kind of fresh and recruiting from different sectors and things like that, I think is part of the sustainability, I think, of our working together. And then we sometimes introduce new faculty. So on the research side, who might be interested in working with them and introducing them to not only faculty. So, I think it's both sides of the whole advisory board composition, and they're wanting to engage in prevention research, but also faculty who might want to work with us, to work with them, or who have projects that might benefit the Southwest Georgia community.
That's great. Thank you. And Allison has added in the chat box about some additional partners and working on a grant. So that's fantastic. Okay, before we wrap up, I have a quick 2-part question that I know that our esteemed panelists will be able to answer in 30 seconds or less, though I would love to have a full hour discussion just about this brief question, and I think our scholars would too. So maybe we need a part 2. But first part is, what excites you about doing implementation science work? So what is one thing that you would share that really excites you about this? And what is one lesson that you would share with these scholars who are potentially embarking on a career in dissemination and implementation work around cancer prevention and control? So what excites you and what one lesson learned? So Dr. Brenner, do you want to go first this time?
Sure. I think it's simultaneously what I like about it and what's the biggest lesson is it's very real world. And I really like figuring that out. But as I said, you never know what's going to happen. You never know your roadblocks. Another program that I've worked with down in Austin doing a similar thing couldn't mail out their fits for a few weeks because if y'all may recall, has probably gotten drowned out by COVID, but there was the Austin mail bomber that was sending random packages, and they decided sending random packages to people while these random exploding packages are going out is probably a bad idea. We never expected COVID. So you will always run into interesting problems, and they're can be fun to solve.
Yeah, I think mine is totally similar, Daniela. I really like implementation research because I think it can impact public health directly. It's not just doing research for research sake. A lot of times we have real world practice that we're either implementing or evaluating. So I think it's moving the needle on public health outcomes that way. So that's, to me, it's always exciting, whether I'm working with CDC programs or pediatric cancer centers or FQHCs around HPV prevention. The other thing I think is exciting, but also challenging is just understanding different contexts and, who's delivering, what is their whole history with using evidence-based practices, or, how do you have to get them up to speed? And so it's challenging yet fun at the same time, because I think many of us who are in this like doing the training and technical assistance that you kind of are hearing that I'm embedded in a lot of my projects. So it's really understanding their needs and trying to address that as we study implementation or roll out a new evidence-based program.
Fantastic. All right, we are at the hour, and I want to thank Dr. Brenner, Dr. Escoffery for sharing fantastic information about the implementation work that they're doing. Thanks to you all for joining. Please, we're going to reach out and get ideas from you for future webinars. We're excited to see you all moving along in your Trello boards and connecting with work groups. So stay tuned for more information from us, from Christine, and from Sam. We look forward to continued collaborations. Thank you all so very much. And we will have the recording available too. And I think we'll be able to share slides. Our speakers feel comfortable with that. Fantastic. Thank you all so much. Have a good rest of the day.
Thanks, everyone.
Thank you.
Bye.
Take good care.